Okay, welcome back to the next section, pathology. We're going to talk about tolerance. What is tolerance? When we're talking about hypersensitivities, we're talking about immunity, and later on we're going to talk about amyloidosis. So first of all, tolerance. What is tolerance? Is this a good thing? Not very good. Immune tolerance or immunological tolerance describes the state of unresponsiveness of the immune system to substances or tissues that have the capacity to elicit an immune response. That's from Wikipedia. And this contrasts with conventional immune-mediated elimination of foreign antigens. So there we have the basic description of it. When we talk about tolerance, we have central tolerance, we have peripheral tolerance. So remember we said that central tolerance is the death of the self-reactive lymphocytes, and peripheral tolerance develops after T and B cells mature and enters the periphery. And so this is often triggered by infections. And remember that it depends on where it is originally induced. So as for central tolerance, we're talking about what happens in the thymus, and peripheral tolerance is what happens outside, what happens after the T and B cells enter the periphery. So this is quite easy to remember. So as a general description of central tolerance, this is the main way the immune system learns to discriminate self from non-self, and peripheral tolerance is key to preventing overreactivity of the immune system to various environmental entities. So let's go on and talk a little bit about this, but let's remember that activation-induced cell death or apoptosis can be a result of this. Also anergy, which is when there is non-activation, and also we could have suppression. So considering these outcomes with energy, the CD28 cell, for example, would just be resulting in, oh, I'm getting confused again. Anyway, let's back up and talk about central tolerance, where you may have apoptosis, but if these self-reactive clones get outside, then we have to now have peripheral tolerance, and then with peripheral tolerance there may be some resulting processes such as anergy, where the cell would just sit there and would not be activated. Then we could also have activation-induced cell death or apoptosis, but you could also have the cell turned off, and this is called suppression. So I think I'm basically understanding what's happening with tolerance. So let's continue on and talk about the pathogenesis of autoimmunity. What happens with autoimmunity and how is tolerance involved? Autoimmunity results from multiple factors, including susceptibility genes that may interfere with self-tolerance and environmental triggers such as tissue injury or inflammation. And these promote lymphocyte entry into the tissues and activation of self-reactive lymphocytes and tissue damage. So let's try to describe now the process of SLE, where we can imagine on one side we could have susceptibility genes, on the other side we could have external triggers such as UV radiation, and then the resulting persistent high level of anti-nuclear IgG antibody production. So it says that regarding the model for the pathogenesis of SLE, susceptibility genes interfere with the maintenance of self-tolerance, and external triggers lead to the persistence of nuclear antigens. And then this result is the antibody response against self-nuclear antigens. And then this is amplified by the action of nucleic acids on the dendritic cells and B cells, and the production of type 1 interferons such as, and then TLRs, toll-like receptors become involved. So looking on the left side of this model, for example, which you can't see, we have a failure of self-tolerance with the susceptibility genes. And so we have B and T cells involved, which are specific for self-nuclear antigens. and then this leads to anti-nuclear antibodies, antigen-antibody complexes. And let's think about the other side. The other side, with these external triggers, you could have apoptosis, then defective clearance of apoptotic bodies, which would then lead to increased burden of the nuclear antigens. And again, as with the other side, anti-nuclear antibodies, antigen-antibody complexes. On both sides here, these would lead to the same result, where you would have endocytosis of immune complexes containing nuclear DNA, leading to engagement of the TLRs by DNA, and then stimulation of B cells and dendritic cells by the TLR signals. So on one side you'd have type 1 interferon, um, and then on the other side we'd have this leading to the persistent high-level anti-nuclear IgG antibody production. So if you were looking at a slide of lupus nephritis, what would you be looking at? Well, you would be seeing several wire loop lesions representing extensive subendothelial deposits of immune complexes. And with an H&E stain section, you might see liquefactive degeneration of the basal layer of the epidermis. And the immunofluorescence micrograph would show you the IgG deposits along the dermo-epidermal junction. Okay, so now let's move on. We're going to discuss the basics of amyloidosis. And the way we're going to discuss this is to read slides and what's written in the book and try just to piece it all together. So what is amyloidosis? We know that it is a protein buildup. It's not a good thing. Amyloid is a pathologic proteinaceous substance deposited in the extracellular space in various tissues and organs of the body in a wide variety of clinical settings. So let's think of examples. What types of amyloid do we have? I was just looking at first aid and looking at, I have here first aid, all the books here have the organ systems and the first aid book and the general principles, and basically saying the same thing. And here we have a summary. So AL is the amyloid light chain, AA is the non-immunoglobulin protein, and then we have the A beta, which is related to the Alzheimer's problem. So where is amyloidosis seen at first? Examples would be the kidney, the spleen, the liver, the heart. So remember that amyloidosis is a group of diseases characterized by the deposition of an extracellular protein that has specific protein. So what kind of stain would you use to see it? Congo red stain. So let's talk about the microscopic features of amyloid. What would you be looking at? So with an H&E stain, you'd be looking at amorphous eosinophilic deposits. With a Congo red stain, you'd look at red deposits. And the Congo red stain under polarized light, you see apple green birefringence. So now let's consider the pathogenesis of amyloidosis and consider the proposed mechanisms underlying the deposition of the major forms of the amyloid fibrils. So two major ways here that it could form. First, there could be a production, an overproduction of abnormal amounts of protein. Sorry, let me rephrase that. It's normal protein, but it's overproduced. So this could be, for example, from an unknown carcinogen, for example, a monoclonal B lymphocyte proliferation, and leading to plasma cells, and then immunoglobulin light chains, and then leading to this AL protein There could also be chronic inflammation leading to macrophage activation, then interleukins 1 and 6, affecting the liver cells. Then you'd have SAA protein and a limited proteolysis leading to AA protein. There could also be a production of abnormal amounts of mutant protein. And so there you'd have a mutation, and this is classically a genetic form, and this would lead to a mutant transthyretin, and then you'd have an aggregation and you have ATTR protein. So just to summarize here, what you have is a stimulus, then you have a soluble precursor, then you have insoluble fibrils, and this is what's causing the problem. These proteins are insoluble, and they look like fibers, but the fibers are abnormal fibers, and they don't go away. This has caused a lot of problems. So the systemic types of primary amyloidosis we talked about. So amyloid light chains, AL, then fibrillary protein, kappa or lambda light chains, and multiple myeloma, B-cell lymphomas. So can remember these different types. So that was for primary amyloidosis. Again, the AL is probably the big one, amyloid light chains, fibrillary protein, and multiple myeloma. How about for secondary amyloidosis? Then we have AA, which is amyloid associated. Then fibrillary protein, serum amyloid A, or SAA, and is produced by the liver with ongoing inflammation and neoplasia. So think about RA, SLE, Crohn's disease, cancer, and TB. So let's continue on. We're going to talk about some different types of amyloidosis, and let's see if you can remember what they are. So we'll just talk about some major points. So familial Mediterranean fever. This is a mutation of the MEFU gene and encoding for the protein of pyrin, which is a suppressor of caspase-1. So we have to learn about the caspases. I think there are 3 caspases. So this is caspase-1. So what's involved here? Amyloid AA, fibrillary protein, serum amyloid A. And this is an autosomal recessive disease, so you would have to have both alleles. And we're talking about recurrent inflammation and fever. How about hemodialysis associated amyloidosis? We're talking here about amyloid alpha beta 2M, and the fibrillary protein equals beta 2 microglobulin. So what are we talking about here? Carpal tunnel syndrome and joint disease. So that's hemodialysis associated amyloidosis, and this amyloid cannot be dialyzed, and this builds up over a period of years. So the systemic type of amyloidosis has a very poor prognosis, and this involves what? Can you think of some examples? This could be the kidney, the heart, the liver, the spleen, or the GI tract. That is systemically. How about localized types of amyloid? Senile cerebral amyloidosis, which is what is seen as in Alzheimer's disease. Amyloid alpha beta and fibrillary protein, beta amyloid precursor protein, which is a beta APP or BAP, and then Alzheimer plaques in cerebral vessels is what we're talking about. This is localized types of amyloid. So this is resulting from a these are misfolded proteins, if you were to characterize what this is basically. So more on localized types of amyloid. Senile cardiac amyloidosis involving amyloid ATTR, or the amyloid transthyretin, and fibrillary protein here is transthyretin, resulting in heart failure. So can you tell me some more about some localized types of amyloid, in this case concerning endocrine diseases? Well, it could be medullary carcinoma of the thyroid, which is the involves procalcitonin, adult onset diabetes involving amylin, and also pancreatic islet cell tumors also involving amylin.